Hello and welcome to this special episode of the Bridge Podcast. I am Joyce. With me, I have Jen and Oge. And don't be surprised that we are not in our usual studio today. We had to tweak things up and give you spice every time. Okay. Today, we are diving into an important conversation as we recognize the Sexual Assault Awareness Month. And this month is dedicated to raising awareness about sexual violence, supporting survivors, and also advocating for change. And the theme of this year is Together We Act, United We Change. And we also need to recognize that this theme reminds us that preventing sexual violence is a collective effort and it requires action, it requires solidarity, and also continued. But before we begin, we also need to acknowledge that today's episode will discuss topics that are related to sexual violence, perinatal health, and trauma. And some of this content may be absolutely distressing. So please engage in self-care, whatever that means for you while you're listening. And if you need to pause or step away, we encourage you to do so. And please just prioritize your well-being. I think I learned that from the class of our guest today. So to discuss this crucial topic, we're honored to have Dr. Mickey Sperlich, who is an associate professor at UB's School of Social Work, and also one of our advisors, Bridge. Dr. Sperlich is an experienced midwife, a researcher who studies the effect of trauma and mental health challenges on women's childbearing and postpartum experiences and outcomes. So I don't want to talk too much, just so that we give our guests enough time to talk. Thank you so much for joining us on this podcast, Dr. Sperlich. And to start with, can you share a little bit about yourself and also about your journey? Like what led you to the research and your work in perinatal and infant mental health field?
Certainly. Thank you, Joyce. And I just want to say how wonderful it is that you've developed this whole series and on such important topics, and appreciate all the work that you're doing. Um, so how did I get into research? Uh, okay, I'm going to really date myself here, right? Because I got into doing research before you were even thought about doing research online, right? It was sort of in the days when yes, we had email, but there wasn't a lot of activity online. And also, I never intended to do research at all. So I just kind of had my head down, uh, catching babies, as we call it in the midwifery parlance, right? Like if you've ever been in a room where someone's giving birth, it's very clear it's not the provider, it's the woman. Although I want to pause here and say that not every birthing person necessarily identifies as female, but I will be referring a lot to women in this uh, context because that's been primarily my experience. So um, what I noticed in practicing midwifery was that a lot of my clients had a lot of difficulties with different things. Um, I was seeing some sort of uh, what I at the term referred to as fight or flight responses in women when they were approaching uh, their labor or pushing their babies out, or different aspects of care. Um, and I didn't really know how to think about that or what to do with that at the time. Um, I tried to be kindly, of course, but there was very little guidance in the midwifery world at that time. This was before the ACE study was done, so before we had that sort of collective knowledge about adverse childhood experiences. It was before we even understood that women get PTSD or post-traumatic stress disorder actually at twice the rate of men. At that time, it was still considered to be something kind of just primarily identified with like combat fatigue or trauma from war. So it's taken a large body of research to finally come around to realize that, in fact, women do get PTSD primarily from sexual violence or intimate partner violence. So what I noticed at the time, and just like doing case consults with other midwives and everything, that um, when midwives were talking about their quote unquote difficult clients, what I realized is that, oh, they're probably talking about their trauma survivor clients primarily, right? And that what I knew before I knew anything, at least, was that basic thing of a fight or flight response, um, which now has been expanded. And I could talk more about that too later. But at the time, I just saw it as, oh, okay, something's happened to this person, right? And that was before the trauma informed questions were even posed about, going from what's wrong with this person to what has happened to this person. But I instinctively knew, oh, something has happened here, right? That has made this person's reaction to a gynecological exam so extreme, right? So in talking with other midwives, I realized we had very little information about this in the midwifery world at the time. So I just rather naively thought, okay, maybe I can help, start some research in this area, because it seems to be a thing. All the midwives I talk about, when I talk about it, frame it as trauma responses, they seem to get that, right? Um, and so, and I would say too, there were some really sort of seminal experiences where it was like really clearly laid out to me in my reactions with clients. I had one client who actually articulated this, right? Got going along, laboring, everything's fine, baby sounds fine, she's doing well, everything's great, and then gets to the point of pushing and labor stops, which is, I mean, sometimes you see a little pause point before someone starts pushing. um, Sheila Kitzinger had referred to that as the rest to be thankful phase of your labor, right? Before you start pushing, there's sometimes a pause, but this pause was really extended and the labor was completely shut down. And so I had a conversation with this client, and what she actually articulated was, I'm afraid to push this baby out because I'm afraid this baby will be abused like I was. So what she was saying in that was that, like, right now she can keep that baby safe, right? That baby's within her, no harm will come, right? But once that baby's born into the world, that baby will be subject to the same kind of abuses that she had experienced. So things like that happened that really clued me in, right? So what I did was decide that, all right, I'm going to survey um, women across the country who identify as survivors and ask them about their journey to childbearing or to mothering, right? So I wrote up a survey, and I ran it by some people. I at least had the good enough sense to do that. And one of my midwife colleagues looked at it and said, this is a great survey. I'm just wondering what IRB you're going to run it through, because of course I wasn't associated with any uh, uh, university at the time or anything. And I said, what's an IRB? Right. And so then she explained about ethical research, and that, all research on human subjects has to go through institutional review board review. And so that was a whole new skill I had to learn, and fortunately did learn, and got an IRB approval to do this independent research. And uh, so that's how I got into doing research, was, just as a clinician, seeing this sort of gap in the literature, lack of understanding, and just waded right in, right? So that research ended up forming the corpus of a book called Survivor Moms: Women's Stories of Birthing, Mothering, and Healing After Sexual Abuse. And that it was an amazing project. I reached out to my survey respondents to ask them if they wanted to contribute a narrative uh, to the effort, and I got 80 full-length narratives of women talking about their journeys into motherhood. So very powerful stories. Women shared that it affected them before they got pregnant, during their pregnancy, during their birth, during the postpartum, as a parent, all the way to being a grandparent. I had one woman say that it wasn't until her granddaughter reached the age that she had been when she was sexually abused, that, everything kind of broke open for her, and she realized the extent of some of the post-traumatic stress that she had. And so that's how I got into it. I eventually decided to, you know, go all in on research after a time. I had been in a really bad car wreck and was making it increasingly, some of the conditions I had after that made it increasingly difficult for me to stay up all night like babies require. So I eventually shifted into full-time research.
Yeah, thank you so much, Mickey, for sharing that story. I
Yeah.
mean, yeah, just understanding how much of your experience you've poured into, I mean, your clinical experience that you've poured into this, and then, coming up with that kind of passion, and using that to face research is yeah. I feel like that's what actually bets intervention, when you bring all of those rich experiences and you put them into creating evidence-based research for people to know that this is actually a thing, this is actually a problem, and then, what can we do about this problem? So, I really appreciate that insight. But then let's circle back a bit and talk about perinatal trauma in general. Like, many people may be hearing perinatal trauma today for the first time. And some persons might have actually been experiencing something like that and not even have a word for it or a name for it. So let's circle back and talk about perinatal trauma with your experiences and everything. What would you say perinatal trauma is?
Well, first, just for your audience, perinatal just refers to the childbearing year. So having to do with the pregnancy or the birth or the postpartum period. So, and then trauma, of course, I'm actually doing an entire separate project on how we define trauma in this country, um, but it can be sort of seen in two large buckets. Like perinatal trauma could refer to a a physical thing that happened, a traumatic thing that happened actually during the course of childbearing, right? Um, you know, um, an emergency C-section that has complications or something of that nature, right? So that's like the physical trauma. What I've centered on though is the psychological trauma, um, and how that plays out. And of course, those two things overlap, right? We know that our mind and our body are working in concert, right? So yeah, so that's broadly what perinatal trauma is, how in terms of how I research it is uh, both the effects of past trauma that are showing up for the person in their childbearing year, as well as any additional traumas that might occur, for which people have a psychological um, adverse reaction to that during the course of the childbearing. So that's broadly speaking, you know, how we think about perinatal trauma.
Okay. Also, like just circling back to some of the things you've said about some of the symptoms you saw in some of your patients, and you know, just having to see or to understand if there are actually connections between perinatal trauma and sexual abuse, or is there a thin line between them or something?
Thank you for that question. Absolutely, yes. So when I decided to stop catching babies and go all in on research, I was fortunate to work with my close friend and colleague Julia Sang at University of Michigan on a large study, which was the first large study in the U.S. actually to really characterize the effects of post-traumatic stress on childbearing. And post-traumatic stress is sort of a way in which we can look at the effects of trauma, psychological responses to trauma for people. So I learned a lot working on that project. I worked at University of Michigan's Institute for Research on Women and Gender for several years with Julia on her large study and some other ancillary studies. And so in that, what we looked at not only what's the effect of traumas writ large on childbearing psychological processes, but also the effects of whether you meet diagnosis for post-traumatic stress or you have some of the diagnosis, what would be called partial PTSD or subsyndromal PTSD. And we looked at that, really many different ways, right? And what really, a quick takeaway from that is that primarily it's harkening back to childhood sexual abuse experiences or adult rape or other intimate partner violence experiences, basically things being done to you by another person, right? Those were the things that showed up in the childbearing year, rather than a trauma like living through a car accident or something like that, or a natural disaster or something like that. So to answer the short answer to your question is sexual abuse is very evocative of symptoms during the childbearing year, right? And it makes sense when you think about it because, a lot of the things that happen during the process of going to prenatals and giving birth and all of that are very intimate, right? They could recreate a situation in which a prior trauma happened, and that I've seen that clinically, in doing gynecological exams with women and having them have a really big reaction to that, right? That is really distressing for clients, right? And they may or may not make that connection, right? But some of them do. So to answer your question, yes, I would say there's a really strong connection between sexual abuse and childbearing issues and experiencing your childbearing year as traumatic.
Yeah. Jen, you want to say something?
Honestly, I'm just here like astonished by just
Yeah.
the early research and how like learning all this and going through all this while not engaged in an actual institution at the time. Like you just mentioned about having, what did you say? One of the first surveys?
First, yes.
Right. And so like I'm just thinking as we're going along, like all these things that you're mentioning at the beginning of, this research career and being in a PhD program, I'm like, oh my, like I'm in the program learning it all and being able to like, implement it.
Yeah.
But I'm like, you were doing a lot of this before you were
Absolutely.
actually into an institution. Can we highlight that?
Yeah, absolutely. Yeah. Yeah.
Wow.
Yeah,
So
I mean, I guess I do have an insatiable, desire for knowledge, but for me, it was also just like, why isn't this a thing? Like,
right.
why don't I know this? Why isn't this taught to every clinician in training, and it did feel a little bit like the lone wolf crying in the wilderness, right? In the beginning, and but I'm not alone in that, I don't know if you've ever seen videos of the either doctors Anda or Falidi talking about the adverse childhood experiences study, right? A lot of people know about that now, and they know that the more adverse childhood experiences you have, the greater risk you have for a lot of health and behavioral health
Yeah.
problems later in life and all of that, right? Everybody knows that now, right? Well, not everybody, but a lot of people know that right now, right? But that research was done in the 90s, right? That original research was done in the 90s. And at the time, when they found these dose response relationships between a history of adversity and all of these health problems, they expressed being befuddled why this wasn't like trumpeted out as, oh my gosh, we have to change our care systems, we have to respond to this, we found the quote unquote smoking gun here, right? But it was kind of crickets for them, right? Like it wasn't heralded at first. It was, people didn't refer to it, now if you go on there, that original article has been, referenced who knows how many times, thousands and thousands of times, right? People understand about that now. But when they started out, yeah, that basic understanding of trauma creates more trauma when you're reminded of that trauma, wasn't a thing. Yeah, yeah.
Yeah, Mickey, talking about, I mean, you did mention ACEs and how like adverse childhood experiences can also impact, at birthing stage. Um, how are like sexual violence manifested across developmental stages of a human being? Like adolescents, young adults, adults themselves, and even like how does it impact during pregnancy stage, birthing stage, and even postpartum with birthing for birthing people, and for just people in general who have experienced this form of abuse.
Yeah, yeah. I ended up getting my PhD not only in social work, but also in infant mental health, because I've always been curious about those connections, right? How does trauma show up? How do we transmit trauma to the next generation? Because we do see these patterns of behaviors and problems in families, right? Time and again. And so I would argue that, this starts right away, right? How the relationship that caregivers have with infants, and the extent to which they're cared for. Of course, that influences um, their how they attach with humans, right? That their attachment style, if you will, right? And so an infant that's going through trauma or neglect, they're going to develop an insecure type of attachment, right? So infants and also toddlers and young children, this is the time that their personality is being formed and the way that they're going to be in the world, right? So I would argue the younger you are when this is all happening, it has more of a direct impact on your actual personality development. So, and this makes sense if you think about, a young child is completely beholden to their caregiver, right? The caregiver is their whole world, right? And if the message you're receiving from that caregiver is, you are an entity that can be abused and neglected, the logical thing that a small child takes away from that is that there's something wrong with me, right? I am not deserving, right? Or this is the way that people interact. This is the way that people show their affiliation with one another. And it includes these types of behaviors that we would consider abusive, but which the young child may or may not understand it as such, right? So, of course, this has a large impact on the choices that you make as an older child and as a young adult and all of that, right? Because if you're operating out of the space of this is what I deserve and it's not very much, or, this is the way that humans interact with one another, those are the kinds of relationships you potentially seek out, right? That make sense to you, that influence the choices that you make or the capabilities you think you have, right? So I would argue that trauma, very young trauma, is potentially the most damaging kind of trauma, right? Because it involves the actual development of that child's personality and their way of being in the world, right? Um, Later stages, I would say, trauma that happens prior to pregnancy, but maybe later, maybe an adult sexual assault or something of that nature. Then what matters, I think, is did you get adequate treatment after that to really look at the symptoms that you're having, whether it be post-traumatic stress symptoms or a depression or some kind of reaction. Did you get resolution of those things, right? If you didn't get any type of resolution or healing around that, and then you're carrying that into the pregnancy, right? Then you may or may not understand what's going on, right? You may not understand some of those basic symptoms, the intrusive re-experiencing, you know, uh, I'm seemingly safe here with my doctor getting a vaginal exam, but really I'm back there being sexually abused, right? Um, um, so that can be highly influential, right? And then, of course, the way that you show up as a parent probably reflects the way your parents showed up for you, right? Or what you learned about that. So, and then that, influences your relationship with your child and how you see yourself as a parent. So I would say that, yes, this is, there are developmental epochs that are really important. But the mechanism is the same, were you traumatized? Did you get healing around that trauma, right? Do you have a healthy relationship? We've seen for children, right? That, you can, all kinds of abuse and things can be happening, but what that child needs is one adult. And it doesn't even necessarily have to be the parent, but one adult in your life who treats you with unconditional care and love and is not non-abusive and telegraphs to you that you're a good person and you can make it and you deserve to make it in the world. You just need to have that one person, right? And not everybody has that one person, unfortunately, right? So I don't know if that answers your question or not.
Of course, I feel like you touched like almost like so many other spectrums, especially when you talked about attachment. I started like really thinking about attachment and being a sexual abuse survivor, or being having gone through perinatal trauma, and when it is unresolved as well, having a caregiver who is also supposed to be there for the child going through their own traumas and trying to, settle with themselves and all that, that can actually impact on the attachments they have with their child, regardless of, so long as it's unresolved, it's definitely have high risks of impacting on the attachment, and, end up having the child to, probably develop insecure attachment, like you said, and which could relate to maladaptive adjustment. And it's just, I don't know, it's just seeing how all of these things relate to each other and end up impacting and continue to impact the um, transfer of trauma and aggression, you know, even from childhood down to adulthood. It tells a lot about the interventions that we need right now, that we need a whole lot of interventions to actually help betting people, help children, help survivors of different forms of abuse. And also, you did mention some of your experiences with people. I think you gave one or two examples from the beginning, but like, what are the common emotional or physical or psychological challenges that are being faced by survivors of this form of abuse?
Well, I like to organize my thinking along post-traumatic stress, not that out of any insistence of diagnosing the world, right? And assigning diagnoses to people. But if you look at the features of post-traumatic stress, I talked about the intrusive re-experiencing, right? That goes back to those initial stress responses. You had that fight or flight, or maybe you froze, right? Some people freeze to the extent that they have like a tonic immobility, or what could refer to it as playing dead, right? We also know, though, that for women, sometimes the response is another adaptive response has been referred to in two different ways in the literature, both as fawning and as tending and befriending. And I sort of like the tend and befriend better because it's sort of less, I don't know, fits my feminist worldview a little bit better than fawning, but it's the idea that, maybe you couldn't fight, maybe you couldn't flee, maybe you couldn't freeze. So what you did is try to talk your way out of it, right? And try to appease the aggressor, right? In some way. And so things can show up. I talked about, harkening back to, feeling like that abuse is happening all over again. That's the intrusive re-experiencing, right? And we know that that can show up in a lot of ways. It could show up out of a smell that's the same as a smell that was happening when you were abused, or a visual or it can be, very importantly, for pregnancy and childbirth, it can be what's called a proprioceptive sort of re-experiencing, meaning your body is in the same position that it was in when the original abuse happened, right? And that, of course, you can see how that can show up in pregnancy and childbirth, quite readily. But then we look at some of the other symptom clusters of post-traumatic stress. The other one is avoidance, right? So if you are, and that is you avoid people, places, and things that remind you of the trauma, right? So when you see a woman who's very late to prenatal care, one of the things I wonder about is whether or not she's avoiding kinds of care that might be potentially triggering or activating her to those prior traumas, right? And then you also see the hyperarousal, so like the physical reactions, right? And in the example I gave of that woman like shutting down her labor, right? That would be a way that physical reaction could play out, and it makes sense if you think, a deer giving birth in the wild, if predator is near, can stop the labor and go someplace else, run someplace else. So yeah, and then you also have the symptom cluster of those cognitive distortions, those negative views about yourself or those negative views about the world, right? So all of these things can impact the way you can show up for your prenatal care experience, or the way you can manage labor and birth, even things, and it also affects early parenting, of course, right? Especially if, let's say, the sexual abuse involved your breasts in some way. Breastfeeding can be highly triggering for some women. And also beyond that, women have told me it's not just breastfeeding, but it's just that close physical intimacy, right? If close physical intimacy to you as a child meant you also were being abused, right? Then you kind of don't know where the boundaries are with this little baby that you're having to provide all this intimate care with, and it might be uncomfortable and you might not know what to do, right? So, those are, like I said, PTSD, thinking about that is just a way to sort of organize your thinking about how this could affect pregnancy and childbirth.
Thank you so much, Mickey. I think one of the reasons why I love hanging out with Jen, Oge, and Vanity is because every episode, it's always learning something new. It's always learning one social work keyword or another. And so I just need to like put that out there. I mean, with your experiences, like Oge and Jen said, it's a beautiful walk doing perinatal trauma, because before now I just have like a little knowledge here and there, and I see why a special someone is working with you. I have taken your classes on trauma-informed care, and I wish everybody else can. But we want to know, what exactly is trauma-informed care, and why is it essential when we talk about maternal health, or we talk about perinatal trauma? Why is trauma-informed care essential?
Okay. We have 15 minutes, or we have a couple of days, because I talk about this for a couple of days, but why is it important, right? I mean, at the core, trauma-informed care, right, we know is a philosophy, right? It's a way of thinking about things. It's not a set of prescriptives per se, right? It's that what I mentioned earlier, that worldview of it's not maybe what's wrong with this person, but what happened to them. And if we can understand what happened to them and the adaptations that they made in their life in order to deal with that, then we can better know how to treat people, right? So it also means attending to, so that recognizing, first of all, that trauma is happening, and we know it is happening a lot, right? If we look at the statistics, there are a lot of women report having sexual abuse of some sort or another, right? having intimate partner violence experiences, right? So, so recognizing that, right? And then responding by really looking at what we're providing and trying to determine whether or not it's traumatogenic and potentially traumatogenic for people, or because we know it's potentially traumatogenic and it's just something people have to go through, then how can we adapt our care to help people go through that experience, right? So, you know, there are many principles of trauma-informed care, the primary one being safety, right? And I would argue if you can establish a relationship where a client or a patient feels safe with you as a clinician, that's the most important thing you can possibly do, right? But it's also about trust and transparency, you know, giving people choice, you know, being transparent with what you do, all of these things. Also, importantly, we're talking about maternal health here. We have to bring in the attention to cultural experiences as well, right? And gendered experiences as well, because we know that African American women, people of color are more at risk for these traumas showing up. We know they're more at risk for developing post-traumatic stress, right? And certainly, if we contextualize outright racism and discrimination as a form of trauma, then they're even more at risk, right? And so, how do we adapt our care with all of that in mind? You know, and it's a real problem we have. You know, if we look at the maternal and infant morbidity and mortality rates across this country, you know, we know that we are not doing what we need to do for families of color in this regard at all, right? And so, you know, the NIH has recognized this, you know, that all of their normal mechanisms of grant funding are not getting at this problem, right? And so, you know, I was lucky to be part of a project called Improve, you know, which is where they're reaching out to nonprofits across the country and trying to develop that are perinatally focused and trying to help them develop capacity to address this huge problem that we have, right? And to find ways to develop care that is more culturally appropriate and inclusive, and recognizes this, you know, diversity of experiences of people going through the childbearing year. So I would say, you know, it's essential. It's essential for us at this point to adopt a trauma-informed worldview when we talk about maternity care. You know, this is happening to some extent, but it needs to happen a whole lot more. Yeah.
Thank you very much. I know we have touched a bit about how healthcare providers can create that safe and supportive spaces for survivors. So we might not necessarily need to elaborate more on that. But in your opinion and going by your vast experience, what do you think are some of the best practical practices to improve care for survivors? Maybe touching on some other of the trauma-informed care principles, but just to like learn from you the practical things that we can do, maybe as researchers and even people in the clinical world.
That's a great question, important question. You know, your mind, I think, would automatically jump to, well, let's develop trauma-informed and trauma-specific services for survivors as they navigate the childbearing year. And I have certainly been trying to do that, right? I developed some interventions. I've piloted them, I'm researching them, putting them out in the world, all of that. And I think that's important. But what I've learned is that it's very difficult to install a trauma-specific intervention in a system that's not otherwise trauma-informed, right?
Yes, Mickey.
Yes. How are you going to get referrals to this, you know, great program that you've made unless you have buy-in from everybody? And that includes people who, you know, greet people when they come in the door and people that do ultimately, you know, catch babies, right? Deliver babies, as the case may be. In trying to do this work is that unless we are treating clinician trauma, or at least recognizing that this is an issue, right? We're going to be limited into how we can roll out trauma-informed care in perinatal spaces, right? So especially when you consider clinicians are working very hard. There's often not adequate staffing. They're working long hours. The expectations on them are quite demanding, right? And so now we've asked them to also, provide this extra layer of care that they may or may not have bandwidth to do, especially if something traumatic happens, something happens in the course of care that just activates them to their own history of trauma that may be unresolved, right? Or something happens that is traumatic in and of itself, right? And so I would amend what I said earlier. And when we talk about perinatal trauma, there's a whole another body of literature that's come about looking specifically at birth trauma. So that's things that happen during the birth that are traumatic in nature, right? The emergency C-sections, or losing an infant, or pain that was not properly addressed, these kinds of things. So they're potentially quite traumatic, and a lot of people do experience their birth as a traumatic incident, right? And also, those clinicians are going through those traumas that are happening, right? And as social workers, it is, most of us, I would say, are fortunate enough to have supervision, right? We have a space that we can go to. Hopefully it's reflective in nature, where we can talk through the ways in which our clients' trauma has been activating for us to our own trauma, or that transference and countertransference that happens in our interactions, that kind of thing. That is not a habit of mind in the health world, right? Midwives, doctors, nurses, they don't have that, right? There might be case consults where they go through, okay, what happened in this particular case, and how can we do better? But there's nothing about, and oh, by the way, how are you doing? What happened for you when that was a horrible birth, where that horrible thing happened? There's nothing for that clinician, right? So as a clinician, if you're working in that environment and trying to do what you need to do, you might have to employ certain strategies to go back to those same stress responses of maybe avoiding dealing with certain things that are coming up with your clients, right? Or worse, kind of shaming them for those things, or treating them in a way that is aggressive, right? So there's a whole nother body of literature that has come about looking at obstetric violence, right? So things that clinicians do that are not only not trauma responsive, but actually create more trauma for clients, right? Being yelled at, failures of informed consent, doing things like vaginal exams, or other things when somebody's not ready, or there's a whole variety of things that can happen, right? So how can we, so what can we do right now? I think we need to try to help clinicians, right? Making sure that they get what they need, So I was involved with a project doing just that, trauma-informed self-care projects in different clinical spaces, to try to, encourage clients to, stop and take a moment to breathe, think about what they need, make sure they have somebody to talk to, develop self-care plans that addresses some of this activation that they feel in the perinatal space. So, and at trauma-informed care, we know at its core, it should involve everybody in the room, right? But I think that in this space is actually quite important. We need to, how do we do this? Maybe we need to start in, medical school, midwifery schools, nursing schools, and making sure that this is the orientation. But ultimately, it's sort of revolutionary in nature, because we have to transform these spaces, right? Which will mean maybe less client load, more time, giving people passing time between things, especially if something is problematic, having wellness programs and giving people time off to deal with things. There's a whole lot of adaptations that need to be made at the systemic level, right?
Right.
So, yeah. Anyway, I could go on about that, but I do think it's highly important, that as clinicians, we get to be involved with this as well, you know. And I actually learned that in my own journey, right? In process of working on that original book, you know, I realized that part of what was drawing me to this was some unresolved trauma on my own part, right? And that's a continual process, right? Taking care of ourselves, taking care of others, it's a web.
Yeah, absolutely. I love the mantra that we learn in the doctorate program is that, you're on this journey forever. We are lifelong learners. And so
Yes,
we always
yeah,
should remember that.
yes.
So you touched on a lot of great points. One thing that we really pride ourselves at Bridge is really bridging again those the community practice and research. And given your extensive experience on in the field and in within research, we want to know how can individuals and communities be supportive for those who experience this form of abuse?
Fortunately, there are good supports out there, when you think of like child advocacy centers, where you can provide direct service and response to children who have been abused and also to their non-offending caregivers. That's, those kinds of programs. So making sure people understand about that, making sure people understand about, sexual assault examiners and what they do, and supporting those types of programs and making sure those are in place everywhere with, really highly trained caregivers who can help people who have been experienced, sexual assault later. All of these things require money, right? Right. So making sure that, so agitating and advocating for these kinds of programs to be properly funded, right? Recognizing, if we look at the, attention to, cultural, historic, and gender issues, I would say we need to have, especially in, you know, uh, perinatal spaces, we need to have more clinicians of color, right? So do more training of midwives of color, doctors of color, nurses of color who can be more culturally responsive to clients.
Absolutely.
Yeah. I think also just awareness, right? And we've seen, I can be a little bit hopeful about this because we've seen that with depression, right? It used to be when I was a child, if you were depressed, there's something horribly wrong with you, and maybe you need to go into an institution or whatever, like it was very highly stigmatized in a way, and we've seen that become not the case, I would say. A lot of people now recognize that, oh, and I think that biological connection was a piece of it. Oh, depression is, like it's a chemical imbalance in my brain, and I can take some medication and I can talk through this and I'll be okay. And it's common and it's not so stigmatized. It's, people are not, fired from their job because they have depression or whatever. My hope is that we can do the same thing with trauma responses, right? And with post-traumatic stress, and teaching people at a younger age, right? That this is how trauma plays out in your body, in all different ways and unique to you. And here's some things that you can do to support that. So we need to go to the educational pieces, right? The nonprofit that I'm helped create to put out one of the perinatal interventions that in the world also has my buddy Julia has co-created a textbook curriculum for high school students around this. And so why not? This is a basic life skill. How do I deal with trauma and adversity when it comes my way, right? What are adaptive responses? What are maladaptive responses? Some of the responses we have initially are very adaptive because they get us out of the situation. They help get us out of danger, right? But over time, they can be maladaptive if you are avoiding a lot of things in your life, or if you're constantly being reactivated or whatever, so making sure that people have this basic understanding that this is just how humans work. This is how our organisms work, right? And my hope is that over time, this can also be destigmatized, right? I think we can take the example of the VA is really working on that, right? I try to really destigmatize PTSD, right? And so they have really great PTSD programs for soldiers who are no longer in service. I think there's still a little bit of stigma because if you admit or are diagnosed with PTSD in a sensitive position in the military, then you can lose your position, right? So there's still that level of stigma there. But I would say, yeah, that's a way that we can support is just normalize this, right? That something bad happens to us, we're going to have a reaction, and it's gonna change us.
Yes. Yes, thank you for giving me that thorough answer.
Honestly, yeah.
It was really helpful, that breakdown. Thank you so much. And this does wrap up just a portion of our questions. Thank you so much for answering them all. And you've given us and the audience some really good information.
Insight as well, yeah.
Yeah, for us to really be able to take with us whatever journeys we're on, whether that's research, whether that's practice, what that is within the community. So grateful for that. But I do want to ask you one final question. Just any final reflections? Do you have anything else that you might want to touch upon as far as like healing and empowerment in relation to this topic?
Yeah. I guess just to say, sometimes, just working in this space, it can really bring you down, right? When you look at just the sheer volume, the numbers, the situation. But I've been at this long enough that I have seen change, right? When I started out at this, we didn't understand that women get PTSD really. No one was talking about survivors in the way that we just all do now. There was very little in the way of perinatally focused trauma specific programs out there, and now there are. So I think just taking that long view, right, that we're going to be in this journey and this struggle, and it's not going to stop, right? And that we will get there. It might take a while, but we'll get there.
Thank you. Thank you so much for your insights, your knowledge. And I think our audience have also picked one or two of them because I have picked so many
Of
things.
course, yeah.
Thank you for being here with us today. And if you're listening to us and you need resources in Buffalo, we have the Child and Family Services, Crisis Services, the Family Justice Center. We have Rahama also, that is a culturally sensitive organization. And we're also going to link Dr. Sperlich's book in the caption so that you can read and understand for yourself the importance of this topic. So thank you once again, Dr. Sperlich. If you found today's discussion meaningful, please subscribe, share, and stay connected with all our social media platforms. And don't forget, it's Sexual Violence Awareness Month. Spread everything that has to do with sexual violence prevention. And we'll see you in another episode. Bye.
Thank you, guys.
Thank
Bye.
you.
Such an honor.
And thank you so much for coming. Such a beautiful, yeah.